2024. Another one works. Okay, we're looking at the respiratory system, and we talk about what are the major functions of the respiratory system. Well, gas exchange is a big one that's sort of, right up there. In other words, to provide us with oxygen and get rid of CO2. Those are the two big ones. And we know that the driver for breathing fast is CO2. It's never about a lack of oxygen. Well, I shouldn't say never, but it's usually never. I would say usually. We'll quantify it there. Um, the driver for breathing rapidly is always about CO2. CO2 accumulates from Krebs cycle, and because we're burning more glucose, and so as the CO2 goes up, we breathe faster to get rid of that CO2. That's why we breathe faster after exercise, is not to get more oxygen, but to get rid of the CO2 we're releasing as we oxidize the glucose. So, respiration. 4 things have to happen. It isn't just breathing in and breathing out. So we call this pulmonary ventilation. Air goes into the lung. Yes, it is breathing in and breathing out, but that's only the first part. And we get air moving into the lungs and air leaving the lungs. We have external respiration, where we have a gas exchange between the lungs and the blood, the alveoli. 1 cell layer thick structures, these little sacs that look like grapes at the very end of the bronchi, the respiratory zone in the lungs. Each alveoli is surrounded by up to 100 capillaries. They're 1 cell layer thick apart, and the gases diffuse right across. It's a passive process. There's always higher oxygen in the alveoli in the lungs than there is in the blood. And so oxygen always goes from a high oxygen to a low oxygen, diffusing right across down its concentration gradient. And CO2 is in the blood. It's always higher in the blood. The partial pressure of CO2 is always greater in the blood than it is in the lungs, and it diffuses back out the other way. And so we have this tremendous capillary network around each alveoli, up to 100 capillaries. And so that is external respiration. Now, the transport, it's not enough just to get the oxygen into the blood and the CO2 out of the blood. We have to move it around. And that's where we use the red cells to accumulate to collect the oxygen, trapping it in the hemoglobin. And so we carry the hemoglobin molecules inside the sac called the red cell, and that delivers the oxygen and carries the oxygen around. And oxygen is always diffusing out of the red cells into the plasma through the membrane of the capillary. And carbon dioxide. Carbon dioxide moves into the capillary. Some of it dissolves in the capillary in the plasma and forms carbonic acid. And a great deal of the carbon dioxide is captured inside the red cell and brought to the lungs that way. And then, of course, that's the transport. Once we get to the target cells, which are all the cells, except cartilage, by the way, cartilage doesn't get, the cartilage like in our knees and at the end of our nose and our ears don't get supplied directly. They don't have their own blood supply. They have to depend on diffusion from adjacent tissues. So they're not going to get their blood directly like all the other cells do, which is one of the reasons why a cartilage injury takes longer to heal, because it's not getting a direct supply of blood, it's getting it indirectly. But everybody else, we're going to have the internal respiration effect here, where we are releasing the blood, releasing the gases, the oxygen from the blood cells into the plasma, into the tissues, and the CO2 is leaving the tissues and going into the blood. That is what we call internal respiration. So you have pulmonary ventilation, breathing in and out, external respiration, exchange between the lungs and the capillaries, transport, moving all the blood around, and then the internal respiration, the actual exchange at the target cells, which are all the cells except cartilage. Now, the alveoli are these sacs made out of simple squamous epithelial cells, one cell layer thick. I've used the analogy of single-ply wet toilet paper, and that's still pretty massive if you compare the thickness of single-ply wet toilet paper to a one-cell membrane. But it's the best I can do to give us an idea of how thin this would be. Some of Walter State's finest toilet paper will just, we all know what that, we've probably all experienced that kind of paper. So anyway, the alveoli are these little sacs. They're hollow. They are surrounded by capillaries. These red things are the capillaries, but it's also surrounded by a lot of elastic fibers. The alveoli are elastic. They can expand. As we suck in air, the alveoli will expand to accommodate that air. And then when we breathe air out, the alveoli will shrink a little bit. Those elastic fibers let it move. The advantage of this is that as the matter of moving air in or out, the pressure inside the lungs stays fairly constant. Remember, and all these alveoli are interconnected with each other. They all have channels that connect. So this alveoli here is not going to swell up suddenly like a balloon, while all the rest of them are just sort of running around the size of a marble or whatever. So we're going to keep a constant pressure in the alveoli. And you see lots of smooth muscle, lots of elastic elastin around here. So this whole thing it's moving when we breathe. Now, when we get down to the cellular level, here's what an alveoli looks like. Sort of made of simple squamous epithelial cells. Again, one cell layer thick, and designed to allow diffusion across the membranes, from one side of the membrane to the other. So here is an alveolar structure right here. There is a capillary. There's another capillary there. Now inside the alveolus, or alveolar structure, we have two types of cells. We have type 1 that make up the alveolar wall. It's plain old simple squamous epithelial, one cell layer thick. That's what's making up the membrane, not the wall, but the membrane of the alveolus. But we also have randomly scattered through here type 2 cells. Most of the cells are type 1, but type 2 cells make surfactant. And if you remember from lab, surfactant is sort of like detergent. You know how detergent breaks up fat and makes things slippery? Well, that's what the surfactant does. Surfactant is going to break the surface tension so that the alveoli don't stick together. So instead of being, like two pieces of wet paper stuck together, the alveoli will not stick, and they'll be able to inflate constantly, as long as they're healthy. And so that's what the surfactant does. This is very critical right at childbirth, because the baby's coming out and the baby takes its first breath of outside air, and the lungs need that surfactant so that the alveoli don't stick together. They've never breathed before, because when they're in utero, in the amniotic sac, they're not breathing air, they're getting it indirectly through the circulatory system. Their own umbilical vein is bringing in oxygen to them. The lungs aren't working until that first breath, triggered by a rise in CO2. Remember, baby comes out. Let's just say baby comes out in a normal position, head down, and the placenta detaches, and now the baby's running on its own stored oxygen, and it's not exchanging CO2 anymore, but its cells are all busy churning out carbon dioxide. And as the pressure rises, I mean, as the CO2 levels rise in the baby's blood, that's going to trigger the baby's medulla to say, to tell the lungs, take that first breath. And that's where the surfactant is so critical to make sure the lungs aren't sticking together in here. So, and this is a constant thing. We always have the type 2 cells making surfactant, so our alveoli aren't going to stick together. Now, here we see the thickness of the cell membranes. Here's the alveolar cell membrane. Here is the membrane from the capillary right here. And there's a red cell with its membrane. So oxygen can diffuse from the alveolus across the alveolar membrane, across the membrane of the capillary, and then across the membrane of the red cell. 3 cell layers. Well, oxygen can do that pretty well. You get, if you had 10 cell layers or 7 or 8 cell layers, the greater the distance oxygen has to travel to get across the membrane, the harder it is for diffusion to work. This is one of the problems we have, like with pneumonia. In pneumonia, this layer here often fills up with mucus. It thickens the membrane inside the alveoli. And so as it gets thicker, it's harder for good gas exchange. It's harder for oxygen to go across the membrane, and it's harder for CO2 to come back across the membrane. So a patient with pneumonia will have, difficulty in breathing. You'll see their CO2 levels in their blood will probably be rising because the CO2 is not getting into the lungs, and their oxygen saturation levels will probably be dropping because they're not getting good gas exchange. Now, what causes us to breathe? Well, I mean, the medulla tells us to breathe, 15 times a minute. That's our normal respiratory rate. There are going to be changes in the air pressure inside the chest. We all know that when the medulla says it's time to breathe, the intercostal muscles contract and the ribs rise and the diaphragm drops and the thoracic cavity enlarges. And since the lungs are glued, since the parietal flora of the lungs, covering the lungs, is glued to the inside of the thoracic cavity, when the thoracic cavity enlarges, the lungs go with it. Diaphragm drops, ribs contract and rise up, lungs expand. This causes a change in the air pressure inside the lungs. Now, there's not a great deal of change in here. We're surrounded by air. The air around us has a constant pressure. I'm not gonna, if I step over here, oh, this is better, it's less pressure over here. It's a pretty that's ridiculous. It's a pretty constant pressure of air pressure, probably somewhere around 760 millimeters of mercury air pressure that we're exposed to right now. We're about 1,000 feet above sea level, and we don't notice any change. This is fine. So that's the pressure of the air surrounding us, pushing in on us. Now, the pressure, that is atmospheric pressure. The differences between a negative and positive pressure in the lungs is usually less than 1 atmosphere. What that means is when your chest rises, your diaphragm drops, and the lungs expand, the air pressure inside the lungs drops. And we'll get into Boyle's law here in a minute. But because you've increased the volume of our lungs without, in that time frame from increasing the size of the lungs and before air rushes in, the pressure inside the lungs is going to drop because you have more space and less air, and the amount of air you had there before isn't enough to fill up the lungs. If your lungs double, if you have a liter of air, a liter of nitrogen oxygen mix in your lungs, and your lungs suddenly double in size from 1 liter to 2 liters, more or less, and you still have a liter of air inside your lungs, but now you have twice the space. So you actually have less pressure. If you increase the size of our lungs, the pressure drops. Now, what happens if we have reduced pressure on one side of a membrane, or in a balloon or something? The lungs get bigger. The amount of air inside the lungs stays constant. So the lungs double in size, but the air that was in there was designed for a 1 liter size lung, and all of a sudden the lung is 2 liters in size. You've doubled the size of the lung, but you haven't changed the amount of air. The air pressure, there's less air now in the lungs than there was before, based on the size of it. Simply because you have more space. If we all went into, if I made everybody sit together in the first 3 rows over here, all jammed in, okay, you would feel crowded, correct? Okay, so imagine the first 3 rows over here is the inside of a lung at rest. You're all packed in there. Each one of you is an oxygen molecule. So, and you don't have to do the Mickey Mouse with the hydrogens to make the water molecule, but so you're all packed together here in this first 3 rows, and everybody's jammed in, and this is the first 3 rows are the lung at rest, and then the lung expands, and the lung expands to fill up the whole classroom. And you're all jammed in here. Your oxygen molecules jammed over here, and suddenly you fill out all the spaces. Are you as congested as you were before? Are you as crowded as you were before? Thank you. No. So, because you have more room to move around in. Because if you're an oxygen molecule, you're walking around and you're bumping into other oxygen molecules. I'm going to get dizzy if I keep doing that. But you're bouncing into each other in these 3 rows right here. And all of a sudden you expand to the whole classroom, and now you can walk around bumping into each other. The pressure is lower when the size increases. And so the amount of air pressure now is slightly negative. The air pressure in your lungs is slightly negative when the volume increases. The outside air pressure hasn't changed, but now you're slightly lower inside the lungs than the outside air pressure. Guess what happens? You have higher pressure outside and lower pressure inside, and your mouth and nose are open. What's going to happen? Which way is the air going to go? When we do this 15 times a minute, I mean, come on, think about it. Your lungs get, you breathe in and out, but what drives you to breathe in and out? Forget the medulla. You have higher pressure air around us all the time. Slightly lower pressure inside the lungs when they enlarge. Which way do things go when air moves? When things move, they go from high to low. So you have the higher pressure outside the lungs and lower pressure inside the lungs. And when our lungs expand, air rushes in. And that's, we don't have to, it isn't like we're sitting here trying to breathe like that. It just, air will automatically rush in as the lungs expand until we reach equilibrium. So just a very slight change in air pressure from what we had before, when the volume increases in the lungs, the pressure drops, and that causes the outside air to rush in. That's how we breathe. So now we got all this extra air inside our lungs. You're all scattered around through here. In the classroom, you're all over here. You're all moving around, and you're all happy. And all of a sudden, we all have to go back over to the first 3 rows again because it's time to exhale. So you all move over here, and the space shrinks. And so when you move everything over here into the small space, suddenly the pressure inside the lungs is greater than it is outside. So now the high pressure is inside. What's it going to do? It's going to go out. And so we breathe out. So the whole purpose of breathing, the whole ventilation is this ventilation is based on the movement of air in and out of our lungs, based on a very slight change in the pressure inside the lungs versus outside the lungs. That's what drives the air movement. We don't physically have to suck in air. It happens automatically as we simply, what we're doing when the lungs, when the ribs rise and the lungs expand, we're lowering the pressure inside the lungs. That draws in outside air. When the ribs relax and they drop down and the thoracic cavity shrinks, the pressure inside the lungs is greater than the outside air and it leaves. So it's not a vacuum, it's just a slight change. It's going from a higher pressure to a lower pressure. When our lungs expand, the pressure inside the lungs drops. Doesn't go to a vacuum, but it drops. It drops just a couple millimeters lower in pressure than the outside air. And so with lower pressure inside and higher pressure outside, the air pressure rushes in. And then when you get ready to breathe out, you raise the pressure by shrinking the chest cavity. You raise the pressure just a couple millimeters greater than the outside air, and that higher pressure air in the lungs forces its way out. And so you don't have to say, "Oh, I got to take a breath." There, I feel better now. It happens. All we have to do is inflate the chest or deflate the chest. Essentially, we're not even deflate. We're just raise the chest or lower the chest. Raise the diaphragm, lower the diaphragm. When our lungs expand, our diaphragm goes down. It enlarges the entire thoracic cavity, and so with the lungs glued to the inside, they get bigger, and it only takes a very short period of time for that to occur. And when we enlarge the lungs, we have less air inside, pressure drops.
Well, barometric pressure though takes a toll on my lungs. With like higher altitude, and I find that right there. I don't know what the barometric pressure is. It's not very large. And so there's a significant difference, which you get oxygen starvation. There's not enough driving pressure.
Right.
So it becomes more of an effort, not just just taking a breath in. It becomes much more.
That's exactly right. Remember, air pressure, the amount of oxygen in the air is cut in half every 10,000 feet. So if you were to go to, I don't know what Mount Rainier is what, 20,000?
I think it's a little higher than that.
Okay, it's not as high as Everest, but it's in the, so if you were to go to Estes Park, I'll go back to my favorite analogy, because I suffered at Estes Park. So Estes Park, Colorado is 10,000 feet elevation. Remember, Denver is the mile high city, 5,000 feet of elevation. Well, Mount LeConte's higher than that. Mount LeConte's like 6,400. But you go up for every 10,000 feet of elevation you get, the amount of oxygen and nitrogen in the air is cut in half. So if the air pressure here at sea level is 760 millimeters of mercury right here, if we go to 10,000 feet, that's cut back to 380 millimeters of mercury. Sea level, 10,000 feet. Now the ratio is still 80% nitrogen, 20% oxygen. That hasn't changed. What has changed at 10,000 feet is the number of particles in the air. As we say, the air is thinner. because there's less oxygen there, there's less nitrogen there. The ratio is still the same. You know, we can even calculate the partial pressure of these two gases. You know, we can see what oxygen contributes at 760. 20% of 760. You know, oxygen is, you know, air is 80% nitrogen, 20% oxygen. 20% of 760 is about 180. Get that right? Oxygen. Pressure of the oxygen is about 180 millimeters of mercury. That's the pressure of the oxygen molecules hitting us, bouncing off of us right now. We don't feel it because we're used to it. We're all used to it. But that's the air pressure pushing down on us from this column of air above us. The pressure of the nitrogen is 80% of 760, and that is about 550, I guess, somewhere. Well, over 500. I might. But the important one is the oxygen. At 10,000 feet, those numbers are cut in half. So if you're at 10,000 feet, instead of 180 millimeters of mercury pressure, is that right? Yeah, 20 times 760 is, oh, it's 160, sorry. 180, 160 millimeters of mercury pressure. At 10,000 feet, now you have only 80 millimeters of mercury pressure oxygen. What that means is that you have to work harder to get air. You have, at 10,000 feet, you have 50% less oxygen and nitrogen in the air. So you have to work harder. It is not nearly as passive as it was before, because now the amount of air, the amount of oxygen you need is cut in half. And if you go up another 10,000 feet, it's cut in half again. So instead of 80, you're at 40 millimeters of mercury, because now, oh, look, there's an oxygen molecule. There's another one. It's really like you can't survive without oxygen above 10,000 feet. So the pressure, you know, the pressure relationships are still there, but it's a whole lot harder to get the oxygen you need because there's less oxygen in the atmospheric air. So, and that's what you, if you go to Mount Rainier, that's what you would
It's
experience.
15,000.
Okay, well, still that's
Still pretty good.
so yeah. So you're going from 160 to 80, and then you would be probably about 60, maybe
Probably.
something, or 60, or it's not as bad as 20,000. So
This
it's
is what
still.
the is the alveolar air inflation.
Yes. So we see that now, unless you're working somewhere at a higher elevation, or your patients are, you know, let's assume for right now you're dealing with a healthy patient, you know, we generally shouldn't have a problem at sea level with the amount of oxygen present. But you know, if you go to higher elevations, your patient, you know, if they're not acclimated, they may have trouble. So, okay. I apologize for going down that big rabbit hole, but that was just, you know, I just jumped into it. Okay. Now there are a series of pressures we deal with in the lung and in the thoracic cavity. We have what's known as the intrapulmonary pressure. That is the pressure within the alveoli. That's what's keeping the alveoli open so they don't collapse. So you have a pressure of the air in the alveoli. You have the intrapleural pressure. That's the pressure in the pleural cavity. So the pleural cavity, here's your lung. This is the lung, by the way. I'll just make sure you see it's the lung. In case you thought it was a funny looking kidney. But this is a lung. The lung is inside the parietal pleura. And then on the surface, we have the visceral flora. Well, there's a cavity in here, and that's the pleural cavity. Just like any other serous membrane, like the pericardial cavity, we have the visceral and parietal pericardium, we have the visceral and parietal peritoneum. So here we have with the lung, we have the parietal flora and the visceral flora. And there's a certain amount of pressure pushing against the lung in the pleural cavity. What is the pressure inside the pleural cavity? So we have pressure inside the alveoli pushing out. We have pressure in the pleura pushing in. The pressure, the intrapulmonary pressure, the pressure in the alveoli will tend to be equal with the outside air. So the air pressure in the lungs as the air moves in and out will be the same as we have right here. So the pressure in the flora is always less. It's less than outside air. It's less than what's in the alveoli, because we don't want to have the flora pushing the lungs closed. What the pleural pressure does is create some resistance, so that when the lungs expand, there's a little bit of resistance from the pressure in the pleura, even though the air inside the alveoli are going to be greater or equalized to the outside air. The pleural pressure wants to keep our lungs slightly tense, if you will, so that we have some rebounding that can occur. The beauty of this is that the tension helps keep the lungs from collapsing. Typically, our lungs are elastic. They would love to, they would like to shrink down. The fluid that lines the alveoli. Now, okay, this one I haven't really mentioned too much either. Our alveoli. Okay, here's an alveoli right here. I know you know exactly what it is, but I better label it for you. So, it's one cell layer. The alveoli is covered with a layer of water. Oxygen diffuses into the water here and then goes across the membrane. CO2 is in solution in the plasma, and it diffuses through the water layer here and comes out the other side. This water on the side of the alveoli tends to make it want to stick together. What happens when you have wet paper? It's probably won't work as just walking through the paper. So here's an alveoli, and here's another alveoli, and I put them together, and lo and behold, it's already stuck to each other. Wet surfaces will stick. So the fluid inside the alveoli want to make the alveoli stick together. It's surface tension that does that. So the lungs are elastic and they want to shrink. The alveoli want to stick together and keep reducing the space we have here. Fortunately, we pull the lungs away from that surface tension. We resist that surface tension because the outer layer of the lungs is glued to the chest wall. The lungs, they just don't want to be expanded. They want to, the physical forces here of water in the lungs causes the alveoli to want to stick together. The pressure, elasticity of the lungs wants them to shrink. We have pushback pressure in the pleural cavity, And so the lungs are always fighting this urge to expand. They're fighting against it. They want to stay small. So, but that's good. That elasticity of the lungs and that thin membrane is exactly what we want. The elasticity allows our lungs to expand. Even though when our lungs rest, they shrink down, and what we need that water in the lungs so we can have gas exchange in here. We want that. We need that. But if we didn't have some sort of way to resist that, then the lungs would shrink and stick together and we'd die. So there was a study done back in the 1970s that caught a lot of attention for a while. It was possible. The reason that we can't breathe water to get oxygen like a fish does is because our lungs are not adapted to the oxygen saturation levels in water. So the amount of oxygen in water is much less than we can use. We just can't stick our head into a bucket of water and start breathing it. That wouldn't last very long. But there was a study done where you could take a rat and you could hypersaturate water in an aquarium to where it was the same pressure, partial pressure of oxygen that we would have in outside air. And the rat could swim in the water and breathe the water in their lungs. So the air pressure that we're breathing right now, what did I say it was? It was 160 millimeters of mercury pressure. That's the partial pressure of oxygen in the air. That's perfect for us. Partial pressure in water is like in a tank of water is much less than that. That's why we drown. Some of these drown. Yeah, but they saturated the water with this high pressure oxygen, and the rat went in and could swim with the fish. So simply by making the saturation level in the water the same as the air. So the alveoli of the rat didn't collapse, and there was enough oxygen coming in to keep the rat happy. Yeah. The downside, as soon as they took the rat out, he died. Yeah, I know, it was sad. So they couldn't get the water out of his lungs. It's little tiny rat lungs. So now everybody can go, oh, rat, hey, my rat bit me when I was in psychology and rat lab. So, I never, I don't have a great love for rats. So I had to get shots because of the stupid rat. Anyway, so
Have the rat water. Stay alive.
he would have stayed alive. But when they brought him out, then the amount of water retained in the lungs was more than the atmospheric air could diffuse across. It had increased the thickness of the membrane, suddenly like the rat had cystic fibrosis or something because you had this, or pneumonia, instantly pneumonia, because they couldn't get the water out of the lungs to let the air go across.
What if they would have put it in a hyperbaric?
Well, now that wouldn't work. See that? I don't think they ever took these. The study that further, or if they had put them, a hyperbaric chamber is a pressure chamber that you would put somebody into, and you could increase the oxygen saturation level 2 or 3 times the atmospheric air pressure. You use that for treating someone that has carbon monoxide poisoning, because carbon monoxide has a greater affinity for hemoglobin than oxygen does. But if you raise the pressure of the oxygen, you force the carbon monoxide out. If you have a patient with gangrene because of an anaerobic bacteria, bacteria that hates oxygen, if you raise the pressure around the bacteria with this high pressure pure oxygen, it kills the bacteria because it forces its way into tissues. It's theoretically possible that you could have taken the rat and put him in there and saturated the lungs with the pure air at higher pressure and driven out the water. So, but it did prove that we can't swim underwater and breathe water, but only because the amount of oxygen in the water isn't the same as in the air. So I don't think they were expected the rat to die when they pulled him out, though. I'm sure that. Yeah. Anyway, now we know we have competing pressures in the lungs. That's all the time. Sometimes our lungs do collapse. The lungs stay inflated thanks to the pressure, the pressure gradients inside. The lungs will collapse if we penetrate a lung, for example. If there's some sort of obstruction in here, if a lung will collapse if the pressure inside the lung and the pressure in the pleura equalize, like a penetrating injury. As we like to say, a sucking chest wound, for example. You penetrate through the ribs and you open up the pleural cavity and you open up the lung interior to the outside air. That will cause the lungs to collapse. The pressure difference between the alveoli and the pleura is what is keeping the lungs open. They stay inflated because of you have some pushback from the pleura and you have pushback from the alveoli. And so the pressure in the pleura is while it's pushing back is always less than what's in the lungs. You have greater pressure in the alveoli than you have in the pleura. So it's pushing out. So we keep the lungs inflated. You have higher pressure inside the lung than you do in the pleura. Even though the pleura is pushing in, the lungs are pushing out. The pushing out pressure is greater. So our lungs stay inflated unless you have something sticking through here and opening up the lungs and the pleural space to the outside air. And it equalizes, the lung collapses because of that. So, okay. Let's move on to something that's probably a little easier to grasp here. That some of that the discussion on pressure changes is always sort of dodgy, if you will. I know you're eating it up, but so inspiration and expiration. Pulmonary ventilation, which is another term for breathing, has two phases. We inhale air or we expire air. When air comes in, it has to be cleaned up. It has to go through the nasal cavity, and then we have to blow it out. So we have inspiration. And now you'll notice that when we inhale air, the ribs are going to rise. The intercostal muscles are going to contract, raising the ribs. At the same time, the diaphragm here, you don't see much of the diaphragm. Only the diaphragm here. The diaphragm is going down. You can't. I think they left the diaphragm off the illustration here. But while the diaphragm is just as important. The diaphragm drops. The diaphragm goes down. The diaphragm contracts. It drops. It increases the size of the thoracic cavity because the diaphragm is the bottom of our thoracic cavity. So the chest cavity enlarges. The ribs go up. Diaphragm goes down. Chest cavity enlarges. So that is inspiration. The drop in air pressure inside the lungs is only 1 millimeter of mercury. From 100, let's say 160, or from 760, that's atmosphere here, from 760 to 759. It's a 1 millimeter pressure change, minus 1 millimeter of mercury pressure change as the lungs expand. And that's all it takes. Because that pressure is slightly, the pressure in the lungs is slightly less than the pressure outside. The lungs have expanded. Inspiration, the ribs rise, the diaphragm drops. the thoracic cavity gets bigger because the lungs are, and the lungs go along with it because the lungs are stuck to the inside of the thoracic cavity wall. So the lungs enlarge just enough to drop the pressure by 1 millimeter of mercury, and that's all it takes because outside air pressure is 760. Inside air pressure now is a robust 759. Just enough to cause air to be sucked in from the outside. Fairly passive. I mean, I know we have muscle contractions response, but the diaphragm has to drop and the external intercostal have to rise. Have to contract, cause the ribs to rise up. But we're usually not aware of our breathing. It's only when we get into higher elevations that breathing becomes painful. Is that a good word for it? Painful. Yes. You feel shorter breath at higher elevations simply because there's less oxygen molecules in the air around you. So atmospheric air will flow into the lungs until the pleural pressure and the atmospheric pressure are the same. So when the air, when you're sucking in air, you're not going to have this unlimited and keep sucking more and more air in. The stopper, the constraint on there is when the air pressure is equal to the pleural pressure, the pressure between in the pleural cavity. Once that equalized, once you've sucked in, your chest cavity enlarges, the volume of the lungs increase, the pressure drops inside the lungs. It goes from 760 to 759 millimeters of mercury. And so air is coming in. Once you equalize the pressure between the pleura and the atmospheric air, no more air is going to come in. And so your inhalation phase is over. You've sucked in your air. And you don't think about it because it's controlled by the medulla. I mean, is anybody aware right now that they're breathing? Think about it. And now that I said it, you're probably all thinking about it, but I mean, oh, there goes the other one. We're not, it's an automatic response. The medulla controls the breathing rate. Expiration, yes.
Seems in that last slide that airflow from lungs at its pressure until interpleural pressure equals atmospheric pressure.
Mm-hmm.
But I thought that interpleural pressure is always the less than atmospheric.
Usually it is.
Usually. Okay.
But at the point of breathing, we have to have some check on the air coming in. If we were always less than the air pressure, there'd be no way to contain how much we're breathing in. So the interpleural pressure is when that hits equal, that's enough at that point. I mean, if you think about it, when you take a deep breath and you're sucking air as much as you can, you're really forcing it there towards the end of sucking in the air. You've got some significant pushback because now you're exceeding the interpleural pressure, and it's saying, "Hey, stop! You've got enough." So the balance when they hit equilibrium, that's the size. Okay, that's your breath. So now, so we drop 1 millimeter of mercury, and that's all it takes. Expiration, the pressure inside the alveoli is 1 millimeter greater than air pressure. So at expiration, our lungs relax. The intercostal muscles relax, the ribs start dropping, the diaphragm starts coming up, the cavity, the thoracic cavity starts shrinking. The pressure inside the lungs, inside the alveoli, starts rising because you're squeezing the balloon, if you will. I should have had a balloon squeeze, but because when we're squeezing the balloon, the lungs are inflated and we're squeezing them, we raise the pressure 1 millimeter of mercury higher than atmospheric air. So we go from we went from 760 to 759 to get air to come in. Now we've filled up the lungs. Now we relax those muscles. So the volume of the lungs is now start shrinking, and we raise the pressure to where we're 1 millimeter above air pressure. And so now air is going to move out of the lungs simply because the pressure is greater. And that will continue until pressure, the pressure drops, to atmospheric air pressure, or theoretically to zero in the alveoli. And so then we start this all over again. It's like every 4 seconds we take a breath. The diaphragm drops, the ribs rise. We increase the volume of the chest cavity to where the pressure, we haven't sucked any air in yet, but the pressure inside our lungs now is a millimeter of pressure less than the outside air. So we have a gradient. Air comes in. When the intercostal muscles relax and the lungs start shrinking, we're squeezing that air. We're raising the pressure by a millimeter. And that pressure gradient then forces the air out. That's how we exhale. It's mostly passive. We don't deliberately force air out of our lungs when we take a normal breath. I mean, we can. It's like we can suck air in on a deep breath, but it's mostly a passive process in and out. Now we can, just like in blood vessels, we can have resistance. Resistance is caused by the size of bronchi or the coating on the bronchi or bronchioles in here. If we increase the resistance, we have less airflow. And with less airflow, we have to spend more effort to breathe. As I say, it becomes more strenuous. A person who has chronic obstructive pulmonary disease, for example, where their alveoli are no longer elastic, have to work harder to get airflow. A person who has pneumonia, where you're coating the inside of the lungs with mucus, has to work harder to get airflow because they're not getting good gas exchange. We have resistance. The bronchi, the bronchioles can become narrowed. A person who has asthma, the bronchi can, and they're having an attack, the bronchi can become inflamed and reduce the diameter here. You can have allergic reactions where that the airway will narrow and create resistance. And when you have an allergic reaction to a bee sting or to shellfish or to peanuts or peanut butter or something like that, then you have an inflammatory response in your bronchi that are going to swell up and narrow the airway. So, and that becomes a real problem. Epinephrine, which causes the heart rate to speed up, also dilates the bronchioles. A person who had an allergy to peanuts, a dangerous allergy to peanuts, will frequently carry an epinephrine pen called an EpiPen. And if they are exposed to peanuts, they'll jab themselves in the thigh with the EpiPen and it'll release epinephrine. And epinephrine will cause the smooth muscle to dilate in the airway. So it reduces the resistance. Of course, it's also going to cause the heart rate to speed up too, which is probably not a bad thing at the same time, because if your patient is having an allergic reaction to peanut butter or to bee stings or to some chemical, and they're getting airway resistance, they're going to become, they're going to be depriving themselves of oxygen. So the EpiPen will open up the airway, but it will cause the heart rate to go ahead and probably pump more blood. So it's sort of it does double duty for us. The main thing, though, is to get the airway opened up. Because, if someone is extremely short of breath because they're having an asthma attack or an allergy reaction, an allergic reaction here, and they're having trouble breathing, there's a certain amount of panic involved here. They're going into a fight or flight response too because they're getting all very concerned. I mean, if someone is having trouble breathing, that is, a very immediate life-threatening situation. So, and we see a lot of people, a lot more people with peanut allergies than we've ever seen before. So, so lots of people have EpiPens for themselves or for their children simply because they're have this allergy to peanuts. That 40 years ago, nobody was allergic to peanuts. Now everybody seems to be allergic to peanuts. Now there are some theories as to why. It may have to have something to do with in the childhood vaccines that we all get, measles, mumps, rubella, chickenpox, all the other shots we get when we're a child, that the carrier for many of these vaccines was a peanut oil base, which triggered an allergic reaction slowly over time. It triggered the production of antibodies. That's the best theory I've heard so far. There is a lot of work being done. Totally, we're off the topic here, but we'll get into the immune system tomorrow. That by exposing children who are allergic to peanuts to small concentrations of peanut oil over time and increasing the concentrations, they will develop immunity to the peanut oil and they'll no longer have the allergy. Start with a small powder, very small doses, and then gradually get used to it. So maybe that will correct the problem caused by the peanut oil doses that were used in all the medications. Okay, moving on. Surface tension in the alveoli. I've talked about this many times. Surface tension, the alveoli are coated with water on the inside, and they want to stick together. Fortunately, surfactant breaks apart the surface tension. The surface tension on a paper towel, they then stick together. You wipe up a spill with a paper towel, and the water is sucked into the towel, and the towel sticks to itself. That's because of the surface tension. The alveoli would stick together too if it wasn't for the surfactant. The surfactant breaks apart the surface tension, and that's exactly what we want. Because if they stuck together, it would be hard to get the alveoli to inflate. We want to see compliance in the lungs. We want to have the lungs be able to inflate fully here with no problem. Compliance is how we determine, is the lung working right? Compliance is a measure we measure the change in the lung volume when we change what we call the transpulmonary pressure. So what we look for is the surface tension of the alveoli, and we look for the ability of the lungs to stretch. Can the lung inflate fully? Is there something in the way? Will the lungs inflate fully? Will they stick together? And compliance we measure the compliance by how well the lungs are functioning. What's going to interfere with this? Scarring of the lungs, from infections, creation of fibrosis in adding connective tissue. Fibroblasts make a connective tissue that doesn't do anything. If you have a scar in your body, the scar tissue is made of fibroblasts or fibrocytes. Fibroblasts in the building. A scar doesn't detect temperature or pressure or pain. Scars don't have hair. growing on them. You know, like if you have a scar on your hand or something, you'll notice that the scar hasn't changed since it formed the first time. It's still this little pink oblong spot there. You know, I've got one where I dropped burning plastic on my thumb when I was 11 years old, and the scar is still there. You know, I won't explain why, but just take my word for it. It hurt. But it doesn't do anything. It doesn't fill in. All it does is fill in the space. So if you have scars from infections or inflammation in the lungs, that's going to reduce the ability of the lungs to expand, because scar tissue doesn't do anything. It just, so it's like when you have a hole in drywall and you get some of that spackling compound from Home Depot, the you know, in the little container, and you take it and smear it on the wall and then sand it down and paint over it, and it looks just fine, except there's still a hole in the wall underneath the spackling compound, and the strength of the wall is never quite as good as it was before, and only you know that the hole was there. So when my sons were little, there were lots of holes patched in walls that only we knew about. So anyway, but it reduced this overall strength of the wall. Scarring reduces the overall strength of the lungs. You know, the lungs are no longer as resilient. Just like scar tissue in the heart reduces the efficiency of the heart, because it doesn't contract, it doesn't pump blood. Here, we don't expand, we just have scarring, you know. So that's one of the big things. We can have lots of mucus lining the bronchi. We can, you know, patients with cystic fibrosis is a genetic disorder that causes an overproduction of mucus in the lungs and in the bronchi, and that clogs the bronchi and makes it more difficult for gas exchange. And another area, by the way, that cystic fibrosis affects, because two things we see. A person with cystic fibrosis always has respiratory issues, and they're often smaller in stature than their peers, because that mucus also affects the pancreatic duct. And so it blocks the movement of pancreatic enzymes going into the duodenum to break down proteins. So many individuals that have cystic fibrosis, in addition to respiratory issues, may have lower body mass and a smaller stature, simply because they're not getting the protein they need. Okay. Maybe your patient isn't producing enough surfactant, so the alveoli do stick together. Maybe their rib cage can't expand. Maybe they have damage to their ribs. Maybe they have damage to the muscles. Maybe the diaphragm is being compressed by something. Maybe there's a large, maybe the individual is significantly overweight and has a lot of adipose collecting here in the abdominal region, pushing up against the diaphragm. So it's harder for an individual that is morbidly obese to breathe, because the diaphragm can't come down as far. Many people that that are extremely obese will have, you know, usually have some sort of respiratory issue here. The diaphragm can't expand as far. You know, maybe the accumulation of body fat across the thoracic region prevents the ribs from expanding. So there's all sorts of things that come into play here. Now, ventilation, pulmonary ventilation. We're going to get into some numbers here in a second. This is movement of air into the lungs. It's a mechanical process. There's a lot of, but when we move air in, a lot of that air has to go through dead spaces. Not dead in the sense that they're not alive, but dead in the sense that they're not going to have anything to do with gas exchange. We bring air in through our nasal cavity, into our nasopharynx, into our oropharynx, down to the larynx, down the trachea, down to the bronchi. None of that air is doing any good for us yet. It hasn't got to the area where gas exchange is going to take place. We're still bringing that air down. So it does, there's no ventilation. I mean, the actual ventilation between air going into the lungs and out of the lungs. We haven't even got to the lungs yet. Things like coughing or sneezing or crying, hiccups and yawning, all these, none of these require or will lead to, are going to cause ventilation, because none of those get you to the lungs. Coughing, for example, is caused by the trachealis muscle on the back side of the trachea, that when our bronchi or our pharynx is irritated, we cough and expel air in the bronchi. That air is not going down to the respiratory zone. It's still in the conducting zone, if you will. So, how much air are we breathing? Well, on a daily basis, when we're having a resting breath, we have what's known as the tidal volume. This is what you're doing right now. You're breathing air in and out and in and out. The tidal volume air is you are exchanging about a half a liter of air with every breath. Just sort of here we are at rest. We're not excited. Well, I'm sort of excited, but you're at rest, you're breathing air in, you're breathing air out. 500 milliliters of air in, 500 milliliters of air out. That is what we call the tidal volume air. Now, bear in mind that the entire volume that we can usually deal with is somewhere around 6 liters. And we're only using about a half a liter. So that's just resting breathing, if you will. Now, another term here is called the inspiratory reserve volume. Now we have the tidal volume air of 500 mils. We're just breathing back and forth. But suppose we were to suck in as much air as we could, forcibly drawing in as much air. The inspiratory reserve volume is how much can we bring in past the tidal volume. And that can be up to over 3 liters. A healthy individual with healthy, the intercostal muscles are healthy and the lungs are healthy and they have no infections and they don't have any massive weight issues or anything like that, or no inflammation in the lungs or scarring, could suck in as much as 3 liters more of air. So what about now that you got that air in there, how much can you blow out? We did that in the lab with the spirometers. We were blowing out air. See how much we could blow out. See how much you can suck in, see how much you can blow out. On top of the tidal volume air that's moving out, you could conceivably blow out over a liter of air. That is what we call the expiratory reserve volume. This is extra air that we can force out of the lungs. And then we have the leftover air, the residual volume. That's what's in all the dead spaces. The nasal cavity, the oral cavity, the trachea, the conducting zone bronchi. That's, this is what we call, the residual volume. It looks like this is a chart we have here that you can see it. The inspiratory reserve volume, and the whole amount here is about 6 liters of air. Inspiratory reserve volume, about 3 liters. Tidal volume, about a half a liter. So you could conceivably suck in 3.5 liters of air at any given time. What you blow out, the expiratory reserve volume is about 1,200 mils, and add that to the tidal volume, so you can get almost 2 liters going out. The absolute volume is the air that we're not worried about, the air we don't do anything with, the air in our mouth and our nose and stuff like that. So we have total volume is about 6 liters, but we have a term here also known as the vital capacity. This is the air that we're using. The air the maximum amount that we can inhale, the maximum amount that we can blow out, plus the tidal volume. And that comes into about 4,800 mils. So the average individual's vital capacity is almost 5 liters. 4,800 mils is our vital capacity. That is the inspiratory reserve volume. the tidal volume, and the expiratory reserve volume. How much can you inhale? How much can you blow out? And then you add in the tidal volume too, because right now everybody's doing tidal volume, 500 in, 500 out, 500 in, 500 out. But if you were starting to exercise, your CO2 levels went up, the medulla would say breathe faster, so your you would be dipping into your inspiratory reserve volume. So this is where the air is. These are the quantities of air that we deal with when we take a breath. Now, if you remember back in AP1, I said there was only one law that I wanted you to learn. That was called Wolff's Law. Everybody remembers Wolff's Law. You know, bones respond to the stresses applied on it. Here we have 6 gas laws you need to remember. I think I said something in AP1 about you'll have more to learn in AP2. Well, here they are. So these are the 6 gas laws. Now, some of them are pretty straightforward. The first one is Boyle's Law. Boyle's Law deals with pressure and volume relationships. We have Dalton's Law, Henry's Law, the Bohr effect, the chloride shift, and the Haldane effect. So, and you're going to come to love them all. So, Boyle's Law. Boyle's Law simply says that pressure and volume are inversely related. As volume drops, pressure increases. If you inflate a balloon and start squeezing that balloon and raising the pressure in the balloon, as you start squeezing the balloon, the size of the balloon is going to shrink. The pressure is going to get greater on the inside. So volume and pressure are inversely related, meaning that less volume, higher pressure. Greater volume, lower pressure. If you have the pressure inside a cylinder or inside a balloon or inside a crowded classroom is all about, how often these particles, these molecules, these people are going to run into each other as they move around. Pressure is all about the interaction with air molecules inside our lungs. You blow up a balloon and you fill the balloon up with air, and the more air you push in, the greater the pressure is. The balloon gets bigger and bigger and bigger. Airways want a balloon, right? The pressure inside the balloon is quite high because the air molecules are moving around in here and bouncing against each other. If you were to squeeze that balloon, you can start reducing the size of the balloon without changing the air, the volume of air inside, and now they're bouncing into each other even greater, to the point there where if they find a weak spot in the wall of the balloon, they're going to pop. If we took this classroom and we're all spaced out very nicely right now, everybody's comfortable, right? Okay, so, and what if we went down and got Dr. McEwen's chemistry class and brought them in, and then we went and got the people out of the office and brought them in, and they said, everybody get up and walk around blindfolded and see what happens. And the more people you would put in here, and the more times you bump into them. Now, right now, if I say get up and shut your eyes and walk around, you probably wouldn't bump into each other as often. Let's say we remove all the tables and chairs and you're just walking around here aimlessly. But what if we put another 100 people in here? Now it's really crowded. You're going to be bouncing against each other, and that's pressure. Pressure is the interactions of the molecules or the people bouncing against each other, bouncing against the walls and doors. So when we reduce the size of the chamber or the room or the balloon or the lung, pressure is going to go up. Pressure goes up because all these gas particles are bouncing here. Boyle's law describes this by saying that pressure and volume are inversely related. If volume drops, pressure goes up. Think about squeezing the balloon. We squeeze the balloon, the pressure inside gets greater. That describes how our lungs work. when our lungs inflate, when our lungs get bigger, the pressure inside the lungs drops. You know, the when the pressure when the lungs enlarge, the pressure drops. Volume increases, pressure goes down. When the lungs deflate, when the lungs shrink, the pressure inside goes up. As the volume drops, the pressure goes up and air is forced out. So Boyle's law explains how we breathe, the movement of air across, into and out of our lungs. It's all about the lungs expand, pressure drops. The lungs shrink, pressure rises. So, now, Dalton's law of partial pressures, that's what I was talking about here earlier, when we add a series of gases together. Atmospheric air at 760 millimeters of mercury is 80% nitrogen and 20% oxygen. The atmospheric air pressure is 760 millimeters of mercury. Now, the two gases combined give us that 760 millimeters of mercury. The partial pressure of oxygen is only 20% of the total amount of pressure. It only provides 20% of the total amount of pressure. So pressure from the oxygen is about 160 millimeters. So the 20% of 760 is 160. Okay, so the partial pressure of oxygen in atmospheric air is the contribution to the total pressure of 760. 20% of the 760 is contributed by the oxygen, which amounts to 160 millimeters of mercury. Nitrogen is almost 600. There's many more nitrogen molecules in the air. So nitrogen is contributing almost 600 millimeters of mercury pressure to the atmospheric air. Dalton's law says the total pressure of a gas is going to be the sum of the mixtures of the gases. So the pressure from the oxygen, the pressure from the nitrogen, we add those pressures together, and that gives us the total pressure. We're going to ignore the trace gases in here right now. So this is Dalton's law. Particle pressures will add up to the total pressure. Henry's law deals with carbon dioxide. Henry's law says that gases dissolve based on their particle pressure. So carbon dioxide is much more soluble in water than oxygen is. So we use water to carry carbon dioxide in the form of plasma, to carry carbon dioxide back to the lungs. Carbon dioxide is 20 times more soluble in water than oxygen is. So we don't use oxygen. Oxygen is carried by water. Oxygen is carried in hemoglobin because oxygen can't dissolve in water. That's our poor little rat found that out. So Henry's law simply says that gases dissolve into water based, equivalent to their partial pressures. So particularly, the big one we pay attention to is carbon dioxide. Okay, let's take a short break here, and then we'll come back and move forward. Okay, let's go ahead and pick up here. Gases in the alveoli are different than outside air. Outside air is mostly oxygen and nitrogen, but inside the alveoli, it is oxygen and nitrogen and more carbon dioxide and water vapor. And you'd expect that because you have gas exchange. Carbon dioxide leaving the blood, going into the lungs. Well, that's all sort of being concentrated there in the lungs as it's coming out. You have a lot more CO2 in the lungs than you're going to have in outside air. You're going to have moisture. Remember, the lungs are coated with water. So you're going to have more moisture in the air than you would have in the air we have right here. And we mix the air. So outside air is drier. It has more nitrogen and oxygen and less CO2 than what we have in the lungs. So the lungs are doing their job. They're getting rid of the CO2. There's more water around there, and you are going to keep mixing this air. So we have a difference in there. These are two numbers that you probably need to remember. Partial pressure of oxygen in blood is about 40 millimeters of mercury. This is in venous blood. This is in the dark red blood. About 40 millimeters of mercury pressure. That's partial pressure of CO2. I'm sorry, that's oxygen, not CO2. Got carried away with my, I'll get to the CO2 in a minute. In the alveoli, the pressure is about 100. So the pressure difference in the veins is much between the veins and the alveoli is about 60 millimeters in here. So we have a very steep gradient between the oxygen in the alveoli just before it goes into the blood, as opposed to what we have in the veins on the other side. You know, we go into the so. Interesting. Which one's that? Dr. Price, service dog here. You want to tell them what you're doing? Sure.
Yeah, good girl. Y'all can better if you want. Anybody want to come better? You can come better. The only thing I'm trying to teach her is she doesn't get that until she sits, because she is being trained as a therapy dog. So, yeah. So we are training, I teach here too. We're training therapy dogs to go to nursing home and children's homes and things like that. And this is her very first day. She's only 10 months old. Sit, sit, sit. So this is her very first day of training. Y'all welcome to come better. I'm just trying to teach her that she doesn't get hit until her feet are on the ground. Y'all care about taking a picture? Okay. I'm not just to her on her enough. She's not mine, I'm just training her. So good year.
That's what Dr. Price is about the rest of us. We're not her, she's training us.
Yeah, you stay.
Sure.
Let me get a picture of her. Because like I said, when she came today, I said, please get pictures. So that's what we're doing. Because, you know, we really want people like in the nursing homes who are lonely to have some companionship and yeah. So 10 months old, and this is literally her first hour of training. Thank you. I think she's doing really well. Thank you all. Yeah. I used to work with class a lot. I used to take my lot. I did you? And certifications. Yeah. Put a little sign on their door. Big line. So we are just started. I also have a big black one, and she's another story. Yeah, you're doing really good. Interrupted your class.
That's okay. That's okay.
I knew you couldn't resist it. You saw.
Oh, of course not. You know me. So.
Yeah. So we're gonna be back, I got approval from Human Resources for her to be a therapy dogs or therapy dogs in training. Now I'm gonna be a puppy. Okay, you haven't been a puppy all morning. That they're allowed anytime here, so I'll be back several times.
Okay.
Yeah, because this is what she needs just to meet everybody. Feet down, feet down, feet down.
Oh, you're so
Good, she did.
good.
Good.
Oh, you're such a good girl. Yes.
Considering,
I'll tell my babies about you.
yeah, that she can shake.
Oh, can you shake? Oh,
Oh.
what a good girl. Can you shake me?
She is ambidextrous.
There. Oh, yeah. Yeah, that's wonderful. You're so.
Y'all didn't really want to do anatomy anyway, did you?
No.
Yeah, respiratory.
Yeah,
I guess.
we're all tired. So
Your semester almost over, you guys.
Monday is the final.
I need to bring her Monday for therapy.
Yeah, for me. Yeah,
Lay her out on the table up here.
yeah.
Yeah, you got a lot of puppy in you, don't you? She's like, "Oh,
So,
thank you for interrupting your class. Thank you.
oh, you're welcome. So,
Let's go. Let's go. You good? Yeah. Have a good day.
you too. Thanks for bringing her by.
Feel therapy, what's the word?
I feel therapy.
Therapy.
I'm therapy.
Blood
yes.
pressure goes down, cortisol, but you can talk about that. This is applicable.
Of course.
Cortisol levels drop, blood pressure, heart rate. And she's ready to go.
So, yeah, Dr. Grice is starting her second career in addition to teaching. She's created this, what's the name of her company? Yeah, Pause and Pray. So, and that's the first one that she's brought around. That's great. Okay, back to this topic. Why do we have so much higher oxygen in the alveoli than we do in the venous blood? Well, first of all, because it just sucked in all this air, but we want to have we want to keep a concentration gradient really high. It's a 60 millimeter mercury difference between what's in the venous blood and what's in the alveoli. We want to jam that oxygen into the blood rapidly. It only takes 1/4 of a second, 0.25 seconds, to reach equilibrium with the oxygen in the air, with the oxygen in the artery. So it only takes 3/4 of a second to go through the to be picked up, the capillaries that surround the alveoli. It only takes 3/4 of a second for the oxygen to go through the alveoli into the capillaries and into the red cells. So it's a very rapid process. It's high saturation level in the alveolar air versus a lower level in the venous blood. So the venous blood's coming into the lungs at it's only 40 millimeters of mercury coming in, and now all of it, is being picking up this oxygen, and suddenly it's saturated in 3/4 of a second, 0.75 seconds. So we rapidly pick up oxygen. Now in our blood, we have to use hemoglobin to carry our oxygen, because oxygen doesn't dissolve well in water. So molecular oxygen is carried in the hemoglobin inside the red cell. And we do have a certain amount of oxygen in the plasma, because the red cells have to release the oxygen so that it can diffuse from the capillary into the tissue. So it does go into the plasma. Now there's a term here, another law, the Bohr effect. The Bohr effect deals with carbon dioxide levels in the blood. The Bohr effect occurs when if you are undergoing rapid cellular respiration and giving off lots of CO2, the partial pressure of the CO2 is going to go up. The more glucose you're oxidizing, you're going to be generating a lot of CO2. CO2 goes up, your blood pH starts to drop. Okay, we all know that. So the rise in CO2, the increase in the partial pressure of the CO2 causes our pH to go down. We become more acidic. We all know that. We've been talking about that for 3 weeks. More CO2 means more carbonic acid, which makes us more acidic and we breathe faster. Okay. Well, what the Bohr effect does is that the drop in pH, this increase in acidity, causes the red cells to release more oxygen. So not only does the CO2 control the breathing rate, but the CO2 also affects how rapidly the hemoglobin releases oxygen. Because when we get more acidic, we're generating more CO2, we're burning more sugar, we release this CO2, it becomes carbonic acid, our blood pH drops. Well, that medulla says, okay, breathe faster because we want to blow off the CO2. By dropping the pH by the increased carbonic acid, what we see is an increase in the release of oxygen. The Bohr effect says that as CO2 levels go up and pH goes down, we're going to release more oxygen. So when we really don't need the extra oxygen, but we start releasing it anyway. And so we call this the Bohr effect or the Bohr shift. We see on these curves here, we know that CO2 levels go up when we exercise because we're burning more glucose. We know that it forms carbonic acid and drives our pH down. We've talked about that since May 30th. As we drive the pH down, it allows the hemoglobin, to release more oxygen. And so here we see the if our CO2 levels go up, then look at the red line. If our CO2 levels go up, our oxygen levels are going to rise. The more, the curve says, the more CO2 we have, the red line here, the more CO2 we're releasing, the more oxygen we're going to release. And so the bond holding the oxygen to the hemoglobin weakens when we get more acidic, thanks to the carbonic acid. And so the Bohr shift or the Bohr effect says more CO2 means more acidity, which means we release more oxygen. So just when we need more oxygen, or just when we'd like to have more oxygen, maybe we're just thinking about more oxygen, we're busy blowing off CO2 by breathing faster, and now our red cells are releasing oxygen at a faster rate simply because our pH has dropped. The formation of carbonic acid is driving two things then: increased breathing rate and increased release of oxygen from the red cells. The fluoride shift is another one of those. So the Bohr effect is one of the laws. I think the last one we looked at was either Henry or Dalton. And we looked at the Bohr effect. Now we have what's called the fluoride shift. Red cells are going to pick up carbon dioxide. Red cells are going to pick up carbon dioxide. The carbon dioxide, it diffuses from the tissue. Here it comes, right here, going into the tissue, in the plasma here. Here's a red cell. The red cell is going to carry a great deal of carbonic acid. H2CO3 is carbonic acid. Now, as we bring the carbonic acid into the cell, we have to, what we're going to see here, as the carbonic acid goes into the cell, the red cell is going to be giving up bicarbonate. Bicarbonate is a base. We're having all this carbonic acid inside the red cell, and so we take out the bicarbonate base, but to balance out the concentration inside the red cell based on ion concentration, not on solute particles, we bring in chlorine or fluoride. So, because if we kept the bicarbonate inside the red cell, it would neutralize the carbonic acid, and it would reduce it back to we couldn't carry the CO2 back to the lungs. So here we go. CO2 combined with water gives us carbonic acid, H2CO3. Well, as soon as we form the carbonic acid, we secrete out the bicarbonate that's already inside the red cell. We don't want to neutralize this. We want to use this to the carbonic acid to carry the CO2. If we were trying to neutralize it, yeah, that'd be great. We keep the sodium bicarbonate to neutralize it. We don't want to. We want to keep the CO2 to get it to the lungs. To keep the charges balanced, because the bicarbonate just has a negative charge, we bring in chloride. And so now we have a negatively charged chloride in place of the bicarbonate. This is called chloride shift. Chloride doesn't get to do much in our bodies. Chloride is pretty much usually watched. This is its big moment when it goes in and replaces the bicarbonate. It doesn't do anything to the CO2. And so we pick up the fluoride in place of the bicarbonate. Now, when we give off the CO2, when we take the carbonic acid, there's the lung up here. There's the tissue on the left. This is the lung here. We're in a pulmonary capillary here. When we get to the lungs, the carbonic acid is broken down to CO2 and water. CO2 diffuses across the membranes into the lungs. The fluoride goes out and the bicarbonate comes back in. So we stay balanced. If you're a chemist, it's always important to stay balanced. This isn't a chemistry class. So we don't have to worry about the numbers. What we see is that the fluoride, when CO2 goes into the red cell, it becomes carbonic acid, then bicarbonate leaves and chloride comes in. Chloride comes in to replace the bicarbonate. When we get to the lungs and we lose the CO2, then the chloride goes out and the bicarbonate comes back in and the red cell's fat, dumb, and happy, ready to go again. It's gotten rid of its CO2. It's ready to pick up oxygen and start the whole process all over again. So this is the chloride shift. This is how we carry most of our CO2 in these red cells. Another law, the Haldane effect. It's sort of like the Bohr effect in that it has to do with oxygen and CO2. But here it's sort of the reverse, where we see when CO2 level in the Bohr effect, CO2 levels go up and we produce carbonic acid and we get more acidic, we're going to be releasing more oxygen from the hemoglobin. That's the Bohr shift for the Bohr effect. CO2 levels up, carbonic acid forms, pH drops, hemoglobin gives up more oxygen. The Haldane effect is different. The Haldane effect, when we're giving up, what that is, we give up the oxygen because of the presence of, higher CO2 causes carbonic acid, drives our pH down. We give up oxygen. Then the red cells, after they've given up their oxygen, can carry more CO2 back to the lungs. The same CO2 that was driving the Bohr shift, the Bohr effect, that makes us more acidic, causing the breakdown of the bond between hemoglobin and oxygen. Now that we give up that oxygen, that same red cell, in the presence of high CO2, can carry more CO2 back to the lungs. So the Haldane effect is how we replace oxygen with CO2 to get rid of the CO2. When we get to the lungs and we release the CO2, we can pick up oxygen again. It's the chemistry of how the hemoglobin's working for us. So the Bohr effect is the trigger. The Bohr effect says that at CO2 levels, as we oxidize glucose, we release CO2. CO2 becomes carbonic acid. Carbonic acid makes us more acidic. That causes the hemoglobin to let go of the oxygen. So simply because of the lower pH, and we get more lower pH means more oxygen gets released. It also means now that we can carry more CO2 in the hemoglobin. The hemoglobin has given up its oxygen. or some of it anyway, and it can carry more CO2 back to the lungs to get rid of it. So this is the two differences between, this is the difference between the Bohr shift and the Haldane effect. They're similar. Okay, atmospheric air, the stuff we're breathing. Atmospheric air is somewhere around 20% CO2. It says 21% and 78%, but it's about 20% oxygen, about 80% nitrogen. There are, if you break it out a little further, you've got a trace amount of CO2 in the atmospheric air. Alveolar air, though, is only 14% oxygen, 78% nitrogen, and about 5% CO2. Because at the same time that the alveolar air is getting air coming down from the conducting zone of the lungs, it's getting CO2 being released from the rest of it. So our CO2 levels are much higher in the alveoli than in atmospheric air, simply because we're releasing a lot more of it. Yes, air is coming down the conducting zone, down the trachea, into the bronchi, into the bronchioles, down into the respiratory zone. So we're in the alveoli, but because we have a lot of CO2 being given off by the red cells, that's why the CO2 concentration is higher. You'll notice that the nitrogen level doesn't change much in the alveolar air. It stays around 78 to 80%, but the amount of oxygen drops. Two reasons for that. Because part of the oxygen is already being absorbed by the red cells. Second of all, you've got more CO2 displacing that oxygen. So we have less oxygen and more CO2 in the alveolar air. That doesn't mean that's not necessarily a bad thing, because we have more oxygen going into the red cells. And as we give up oxygen to the red cells, we are replacing that with CO2 that we want to get rid of. The air that we breathe out is about 16% oxygen and about 78% nitrogen and about 4.5% CO2. The amount of CO2 that we're breathing out is still somewhere around 4 or 5% partial pressure, or 4 or 5% of CO2. So we're breathing out a significant amount of CO2, but we're breathing out even more oxygen. So alveolar air will always have less oxygen, because as the oxygen's coming in, it's going into the red cells. At the same time that's happening, the red cells are giving up their CO2 they've been carrying. So it stays balanced in here. Okay, and yeah, I think I said this already. Atmospheric air is oxygen and nitrogen with trace amounts of CO2, but because of the mixing that's taking place in the lungs, the alveolar air is combining with is giving up oxygen and gaining CO2, and so it's fluctuating. Those numbers are fluctuating. Notice that the nitrogen never changes, though. I already said this about oxygen and venous blood versus alveolar blood. So let's move on. Now, how much oxygen does a red cell give up on each pass through the body? Well, it turns out it's only about 20%. Here we have a nicely saturated red cell packed with oxygen, and it goes around and it goes through the whole body. It doesn't take very long, maybe about 20 seconds to go through the whole body. And it only gives up about 20%. The remaining 80% or so is reserve. You certainly wouldn't want to have a red cell giving up all its oxygen at once. And it has to make its way back down to the right atria, to the right ventricle, to the lungs to get fully recharged. It needs to carry that other 80% with it, because You know, what if something happens that it can't get recharged? That is our reserve. That is our 80% reserve of oxygen. What if our demand suddenly goes up? You know, suppose, you know, you have to climb 10 flights of stairs to go somewhere. You know, you are on a hike, you know, on a steep trail. You're using more oxygen. You have more oxidation taking place. You're dipping into your reserve. That's why we have that 80% reserve there. So if we do have greater demands, you know, typical pass is going to release 20% of the oxygen. If we have greater demands, we're going to know it. If we have greater demands in our body, we're going to be burning more glucose, which gives off more CO2, which causes us to release more oxygen from the red cells. So we can get the oxygen we need by breaking the bonds between hemoglobin and oxygen. We may not pick up our heart rate at all. The heart rate may not go up. The respiratory rate may not change. We may just get all the oxygen we need, you know. Because if we're burning more glucose, we're going to need more oxygen for that. If we have greater demands, the only thing that would happen would be that we might increase the breathing rate just to get rid of the extra CO2. But typically, since we carry so much oxygen anyway in our red cells, an increase in CO2 levels, making our blood more acidic, would cause us to release more oxygen thanks to the Bohr shift. So magic number here is about 20%. We only use about 20% of the stored oxygen in a red cell on each pass through the body. Now, I've talked about the thickness of the membranes. We get some real numbers here now. And the thickness of the alveoli is about a half a micrometer thick. Micrometer is 1,000 times smaller than a millimeter. Okay, so it's a very thin membrane. So, and our lungs oxygen does great, you know, going across a half a millimeter thick membrane. It does great going across a 1 millimeter thick micrometer membrane. It can even go across a 2 micrometer membrane, but then it runs out. It doesn't diffuse well after that. We want to have very thin respiratory membranes in the alveoli because the oxygen has to go through the alveoli membrane, through the capillary membrane, and through the red cell membrane. So if the respiratory membranes get larger through inflammation or accumulation of mucus, for example, it makes it more challenging for oxygen to diffuse across the membrane. We love that very tiny, half a micrometer thick membrane. But if we have a patient with pneumonia, for example, pneumonia will cause mucus to accumulate in the lungs. And or cystic fibrosis will cause mucus to accumulate in the lungs, increasing the thickness of the membrane. It will coat the inside of the alveoli, making the alveolar membrane thicker. It'll hinder diffusion. So your person with cystic fibrosis is going to be deprived of oxygen. Your person with pneumonia is going to be deprived of oxygen. A person with emphysema will be deprived of oxygen because with emphysema, you start breaking down alveoli. And if you don't have an adequate amount of membrane, you're not going to have good gas exchange. Emphysema is one of the diseases characterized as a chronic obstructive pulmonary disease. Essentially, in emphysema, the elastic fibers that surround the alveoli stop contracting. They're destroyed. And so the alveoli can't expand and contract. Usually they can expand and then stay stuck and trap air in those structures. So we like to have these, springy, 1 micrometer thick membranes. We don't want to have them full of goop. We don't want to have them not being springy. So. Now, when we get to the tissues, and we have the what we call the internal respiration, where we're taking blood going to the cells, the partial pressure in the cell that we're feeding with oxygen is always lower than what's in the blood. So our partial pressure is always greater in the blood than it is of oxygen, is always greater in blood than it is in the tissues. So, if we are, if the partial pressure of oxygen is 40, the partial pressure in the tissue will be less than that. It's going to be, partial pressure probably around 100 in the blood and about 40 in the tissues. So oxygen will always diffuse into the tissues. The CO2 is always greater in the tissues than in the blood. Partial pressure of CO2 is around 45 millimeters of mercury. It's less in the venous return flow because we're going back to the heart now. CO2 levels are always lower in the blood, in the red cells, than in the tissues. So CO2 will always diffuse away from the cells into the blood, just like oxygen will always diffuse out of the blood into the tissues. Now, I mentioned this earlier we talked about the chloride shift that's taking place here. And this might make a little more sense to the chloride shift. So, we say that we take carbon dioxide back to the lungs to get rid of it, blow it off. And we're regulating that with pH levels. So what exactly happens to the CO2? Well, first of all, only about 10% goes into plasma. So only about 10% is carried in plasma. That's, it forms carbonic acid there because that's what water and CO2 does. It makes carbonic acid. About 20% is bound to the hemoglobin inside the red cell. So we call that carbaminohemoglobin. So that hemoglobin has an affinity for carbon dioxide. The bulk of the CO2 is carried in the red cell as by being absorbed by the red cell and being converted to carbonic acid inside there and kicking the bicarbonate ion out and sodium chloride ion coming in. And so we see the bulk of the movement of carbon dioxide is carried in the blood, in the red cell, as the carbonic acid. And we see that here with the chloride shift again. So there's our CO2 coming from the tissue. It combines to form carbonic acid. We kick out the bicarbonate ion here, bring in the chloride ion, and so now we're carrying carbonic acid in the red cell. When we get to the lungs, we reverse the process, and this is where 70% of the CO2 is carried in this process here. We break down the carbonic acid, release the CO2, and the chlorine leaves, and the bicarbonate comes back in. And so this is the way we carry our CO2. 3 different ways: in the plasma, attached to the hemoglobin, or in the red cell itself. we have a control center in our medulla that tells us when to breathe. You know, it's part of the autonomic nervous system. It tells us to breathe every 4 seconds, 15 times a minute. It is the medullary respiratory center. It's on the dorsal side, the back side, posterior side of the medulla. So it's somewhere back in this region here. And this is, you know, it will trigger the skeletal muscles, the costal muscles, and the diaphragm to do their thing, and the lungs enlarge, and air rushes in, and then it goes out. So the respiratory group will trigger an inhalation. There is a when we exhale, this center goes dormant. So we actively control autonomically, we actively control the contraction of the intercostals and the skeleton and the diaphragm. Now, CO2, as I've been saying all along, CO2 is the trigger for rapid breathing. And it is to a point. You know, let's not blame CO2 for everything yet. We know what hyperventilation is. You know, we probably all experienced hyperventilation at some point or another. You know, we breathe into a paper bag and we feel better. You know, hyperventilation is designed to get rid of CO2 out of the blood quickly. If our CO2 levels are elevated for any reason, we're going to trigger a rapid breathing rate to blow off CO2. That's what we do. But that's only the trigger. CO2 is not the ultimate control here. The medulla is going to take over. You know, yes, we want to get rid of more carbon dioxide, so we're going to have a trigger to breathe faster. But the medulla will determine, based on the pH level, you know, the whole process of hyperventilation. So it isn't, you know, yes, it's caused usually by high CO2 levels, but not always. You know, people will hyperventilate. I mean, someone who starts hyperventilating, did their CO2 levels go up suddenly? You think about it, we say we hyperventilate to blow off CO2. But if you decide you're going to hyperventilate right now, and you're just sitting there, you know, what was the trigger? You know, you know, if CO2 is the driver and you're not exercising, you're not doing anything else, why do you suddenly start breathing rapidly? You weren't stung by a bee, you didn't eat any peanut butter, you know, you didn't eat any seafood. It's kind of making your day really boring now, you know. So why? Anxiety, yes, anxiety. Who's anxious in here right now? Yeah, right? Okay, yes, thank you. Yes. Trust me, I understand. So that could cause, you know, hyperventilation. It isn't always about the carbon dioxide, you know. Now, now you have a situation where you're breathing rapidly thanks to the medulla, but you don't have a lot of CO2 to blow off. You're breathing faster and faster. You're blowing off more and more CO2. You're becoming more alkaline. Medulla doesn't like that either. So it isn't always just about CO2. The medulla is going to respond based on what kind of signals it gets. Now, there's also hypoventilation. Hypoventilation, slow breathing. You know, our CO2 levels are very low, so we slow down. You know, again, CO2 is primarily the driver for most of this. Hypoventilation, CO2 levels are too low, so we slow down. We slow down our breathing. Hypoventilation will fix an alkaline situation. It will, remember, it's an alkaline situation. It's a metabolic situation. The lungs fix. Remember that from yesterday. You have metabolic alkalosis, and so the lungs slow down the breathing rate to retain CO2 and bring your pH back down to where it should be. Acidosis is, we'll become more acidic if our breathing rate is slower. Maybe that's what we're trying to do. Maybe we're too alkaline. We slow down our breathing rate to retain CO2. Perhaps we're retaining too much CO2. Perhaps our breathing rate is so slow that we are retaining lots of CO2. So we have difficulty in gas exchange in the lungs. The membranes are thicker. Where's that you're still turning out CO2 from the Krebs cycle. Where's that CO2 going to end up? It may not be getting into the lungs properly. It may not be diffusing properly. It backs up. So there's a situation. What about lactic acid? You all know where lactic acid comes from, right? Glycolysis in the cytoplasm of a cell doesn't require oxygen. We take glucose and break it down, and we want to get pyruvic acid so it can go into the mitochondria and go to the Krebs cycle, but only in the presence of oxygen. If you have exhausted the oxygen in your tissues and you're experiencing what's known as oxygen debt, and this is a very common situation when you're involved in strenuous activity like hiking or running or something like that. You can't convert pyruvic acid in the Krebs cycle because there's no oxygen for it. And so you convert the pyruvic acid to lactic acid so you can start the whole process of glycolysis over again. What about ketoacidosis? What about your diabetic patient with ketoacidosis? Again, acidosis. So the respiratory system is going to try and fix these situations. If your pH is too high, your breathing rate will slow down. If your breathing rate has slowed down, and you're retaining carbon dioxide, your breathing rate will accelerate. The drivers in a lot of these cases are going to be the CO2 levels. What is one of the big signs of ketoacidosis?
Ketones on the breath.
Ketones in the breath. You smell fruity because you're breaking down the fatty acids and you're releasing ketones, and you're breathing rapidly because ketoacidosis, ketones on your breath, and acidosis, you're taking the triglycerides and breaking them down to fatty acids and glycerol. The glycerol is the problem child for ketones, but the fatty acids are making your blood more acidic. Medulla doesn't know what the cause is. All it knows is it's acidic and you're breathing fast. So now you got this patient breathing rapidly and they smell like juicy fruit gum, because of this fruity odor. Remember that if it's a metabolic problem of any kind, the lungs are going to try and fix it. We acclimatize. Here's another thing that the lungs do for us. We acclimatize as we get used to a higher altitude. Obviously at higher altitude, we're going to be producing more red cells. Erythropoietin is going to be made by the kidneys, and you're going to stimulate bone marrow to make more red cells, but we will also adapt to the reduced oxygen at a higher elevation. Remember, the oxygen concentration is still 20% at 10,000 feet, but the partial pressure is only 80 instead of 160. If the partial pressure of oxygen drops, we respond more to partial pressure of CO2. So we will increase our breathing rate. If there's less oxygen in the air, we will increase our breathing rate slightly in response to increase in the partial pressure of CO2 until we stabilize. It doesn't take more than a few days if you were to go to someplace in Colorado that's 10,000 feet elevation, it would only take a few days to acclimate to the higher elevation and the lower partial pressure of the oxygen. Yeah, and that's all it would take. The drop in partial pressure of oxygen causes a greater response to the CO2, and we see a gradual increase in ventilation rates. Now let's talk about some of the things that go wrong. The lung diseases. COPD, chronic obstructive pulmonary disease. It is a, I don't want to say popular disease, but it is well known among lots of people. Many people have this. The two key features here are emphysema and chronic bronchitis. The problem is the ability to get air exchange into and out of the lungs. Asthma may or may not be COPD, part of COPD. It's sort of, depending on when they have their annual, meetings. Sometimes asthma makes the list, sometimes asthma doesn't make the list. It sort of goes back and forth. So is it a COPD or not? The asthma is, the COPD is the result of permanent damage to the lungs. Asthma is inflammatory. It causes mucus to develop in the lungs. It is a chronic condition, but it may not be causing permanent damage. Many people that have asthma keep it well controlled through some type of either a rescue inhaler or a long duration inhaler like Brio or something like that. Now, let's look at COPD. COPD is a progressive chronic disease. One of the key drivers here for COPD is smoking. Cigarette smoke destroys the elasticity of the elastic membranes in the alveoli, and breathing becomes more and more difficult because the alveoli will expand and not contract. You see with COPD, particularly in emphysema, you would have difficulty breathing. Your patient would have a barrel chest. Their chest would get bigger and bigger because they're trapping air in the alveoli. It looks like balloons on the surface of the lungs. They breathe through their lips because it takes less effort to breathe, to suck air in through their lips. They may be cyanotic. Their nail beds may be slightly blue. Their lips may be slightly blue. Emphysema, upwards of 90% of most cases of emphysema are caused by tobacco smoke. Now there are other causes like if you have a patient that had spent their whole working life as a coal miner, black lung disease can lead to emphysema, depending on where what kind of chemicals are exposed to it in an occupational illness can lead to it. But the bulk of emphysema cases in COPD come from tobacco smoke. Chronic bronchitis is a little different. It's also a COPD disease. What happens here is we produce lots and lots of, we inhale lots of irritants. They cause chronic mucus and inflammation buildup in the airways. It is not like the bronchitis you would get, that's a bacterial infection and you get over it in a week or so. This is chronic. This is long term. Smoking is a big driver for this. Occupational exposure to many different chemicals is a driver for this. The inflammation of the airways cause an increased level of mucus, and so you have a partially obstructed airway, making it more difficult for gas exchange to take place. This mucus causes the patient to trap air in their lungs. The mucus is blocking the air, blocking the trachea, blocking the bronchi, blocking the bronchioles, the smaller bronchi. The mucus continues to respond to these irritants. The lining of the lining of the bronchi continue to respond to the irritants, and they produce more and more mucus to try and protect the bronchi, which simply makes the problem worse. Because now the thicker layer of mucus makes it more difficult for air to get through. And of course, mucus is a breeding ground for bacteria. You know, the more mucus you have, it's a warm, dark, moist environment, and bacteria love that kind of stuff. So now your individual with chronic bronchitis and all this mucus in their respiratory system are going to be prone to some, respiratory illnesses, bacterial-driven respiratory illnesses. And of course, the more exposure they have, the worse it's going to get. And we start destroying or reducing the efficiency of the bronchi, and it gets worse and worse. And it's a progressive disease that doesn't end well for your patient. And since you are trapping so much air, now we get back to CO2 again. You're trapping all that air in the lungs. Means you're not getting rid of the CO2. You're raising the pH. You're dropping the pH in your blood. You're getting more and more acidic. You are reducing oxygen levels, and now that's going to start affecting the central nervous system. It's going to be because of the trapped air in here. Emphysema is the other one. With emphysema, it takes time. It ends the same way as chronic bronchitis, trapping air in the lungs, but it will damage instead of plugging the bronchi, it will destroy the elasticity of the alveoli, and they don't spring back. They don't enlarge and spring back anymore. They enlarge, they trap air, and they get bigger and bigger, but you can't get rid of that air. And so that section of the lungs is no longer useful. And your patient is oxygen deprived. And this is what they look like. This is a lung right here. These are bubbles. These are bubbles of trapped air here. The black area is deposits of chemicals from cigarette smoke, the tars and nicotine here laying on top of that. Notice this person, we know that this person has difficulty in breathing because look at the shape of the clavicles. Your clavicles are not supposed to be coming down at a 45-degree angle like that. This person is working so hard to breathe that he is forced, he has changed the shape of his muscles, pulling his clavicles down. Also notice his mouth. The way his lips are held together like that is how he's sucking air in. And then this is the barrel chest here. It has enlarged because the lungs are trapping air inside here. Individuals with emphysema may end up with lung reduction surgery to take out the portion of the lung that is no longer effective, to reduce the size of the lung because it's inflamed, it's enlarged, trapping air, it's not working. If they're healthy enough, maybe they'll have a lung transplant, and maybe they'll stop smoking afterwards, but you just don't know. Your classic emphysema patient will often look like this. The reason that the chest enlarges, the barrel chest, and the change to the clavicles is we are using different muscles now to breathe. We're using, yes, we're using the costal muscles, but we're using the back muscles and the muscles here in the neck, trying to force that air in. That takes a lot of energy. The reason that you look like this is because, and notice the look at the arms. Look how thin the arms are here. But yet look how big the chest is. This to breathe, to stay alive by breathing requires a great deal of energy. And that energy then is being drawn away from other other uses in the body. So your patient, they look sick, they look emaciated because they are. And again, it's not ending well. So now let's go on here. How do you treat it? Lung reduction surgery can help get rid of the blockages. Again, you're cutting out part of the lung. There are drugs, that are bronchodilators that will open up the inflamed areas, but it may not do anything for the lack of elastic tissue. Oxygen is always being used. So, and now the last condition, lung cancers. Lung cancers, 30% of all cancer deaths in the US come from lung cancers. The 90% correlating with smoking. People that smoke have a 90% risk factor for developing lung cancers. We have three different types. Squamous cell carcinomas from the lining of the bronchi, adenocarcinomas in the lungs themselves, and small cell carcinomas in the primary bronchi itself. And they grow. They spread when they metastasize. You're usually not going to have a slow grower. You're going to see it spreading out. Here we see a PET scan here with inflammation in the lymph node, with a cancer in the lymph nodes down here. There is the upper left lung, and then two more tumors down here that are growing. The PET scan picks up the use of glucose by the cancer cells. So it has spread to two other places here. Now, does that mean this person's going to die? Well, if it's contained like this, that's that's not bad. Remember, there's various stages of cancers. Stage 4 simply means it's growing somewhere else in the original site. Doesn't mean they're going to die. May die, but we don't know that. So now here's what lungs look like. Massive tumors growing in here inside the lungs, interfering with movement of the blood. The tumor can grow into blood vessels. Your patient can bleed out, but it's destroying the ability of the tumors are destroying the ability for gas exchange to take place. So, and on that cheery note, we'll stop. And that's the end of respiratory.